Right. Hello, everybody. Welcome to our Grand Rounds event today. Whether you're joining us here in Rangos Auditorium or somewhere else virtually, we thank you for taking the time to attend our special presentation. Just to say, we've got a few intrepid people here. There is breakfast here. So come on back to Grand Rounds in person if you want. As a reminder, for those that are virtual, there is not a separate link for a meet and greet today. The meet and greet will be integrated into the lecture at the end. So if you'd like to ask our speaker a question, please just go ahead and type it into the Q&A. If you would like to engage with the presenter, ask the webinar host to unmute you and give you access to turn on your camera. If you're attending here in person and would like to engage, just raise your hand and we'll bring you a mic. We also have posted the QR code for today's MOC Part 2 quiz on the doors leading into the auditorium and on the back table with our host for those of you who are attending in person. So get your MOC credit. I have the honor and privilege to have invited Dr. Emily Johnston here to speak with us on the process of quality measure development for children with complex conditions today. Dr. Johnston is a pediatric oncologist who is originally from Iowa and then attended the same college as our division chief, Carleton College in Minnesota, for undergraduate before heading to Stanford for medical school residency and fellowship in pediatric hematology oncology. Her long-term goal is to establish end-of-life quality measures for children with cancer and leverage the measures to reduce disparities in end-of-life care for children. Cancer is the leading cause of disease-related death in children in the United States, making it crucial to optimize the quality of end-of-life care received by children with cancer. However, there are no end-of-life quality measures for children with cancer. And in contrast, on the adult side, the National Quality Forum has endorsed several end-of-life quality measures for adults with cancer. And these measures were instrumental in identifying disparities in end-of-life care for adults and underrepresented minorities and publicly insured, knowing that we now know that they are less likely to receive quality end-of-life care, informing a pivotal intervention research to mitigate health disparities. Lack of end-of-life quality measures for children dying with cancer prevents us from examining disparities in end-of-life care for them. Her long-term goal has required the development of an evidence base for quality measures through semi-structured interviews with stakeholders, including bereaved parents and expert panels. She is currently in the process of determining if those quality measures can be used in real-world settings. And it's also included her using various data sources to evaluate patterns of disparities in care with a focus on end-of-life care. So please join me in welcoming Dr. Emily Johnston.
Thank you, Dr. Maurer, for that wonderful introduction. And thank you for the invitation to be here in person. It's wonderful to visit your fantastic city and enjoying the fall foliage. So really honored to be here at UPMC and present about a topic that I am very passionate about, achieving high quality palliative and end-of-life care for children with complex chronic conditions. And clearly, this is not the usual Grand Rounds topic for a pediatric oncologist. So why am I here talking about this? Fundamentally, I care really deeply about how children die. Clearly, the death of a child is always a tragedy. And at the same time, we can do a lot to make that process as good as possible for the child and their family. I'm concerned, based on my experiences and both my own and other research data, that we are not doing that as well as we can, particularly for underserved populations. Therefore, I have committed my career to addressing disparities in end-of-life care. To start, I want to highlight two cases that really got me thinking about what is high-quality end-of-life care for children, particularly with cancer, since I am an oncologist. And as I read them, I want you guys to be thinking about what is high-quality end-of-life care for children. So the first child was a 17-year-old with multiply relapsed Hodgkin's lymphoma, who had been all over the country for phase 1 clinical trials. He desperately wanted to return home to Colorado to die, but his parents, his decision makers, since he was 17, were not ready for that. Therefore, he ultimately died while receiving chest compressions during a code event in the intensive care unit, something that he did not want, but that his parents did. A second child. So there was a 17-year-old with relapsed T-cell ALL who desperately wanted to go home to die, partially because Make-A-Wish had souped up his car and he wanted to sit in it in his driveway before he died. However, due to his age, the local hospice agencies wanted contract modifications to take care of him because they had never taken care of a pediatric patient before. Therefore, his hospice enrollment was delayed by 3 days and he died in the ambulance on the way home. So to me, both of those children represented things that we could do a lot better to provide high quality end-of-life care for children. It was easy to identify the things that I thought were low quality about their care, but conversely, I thought it was much harder to actually identify what is high quality end-of-life care for children. And these challenges in defining high quality care are reflected in the lack of pediatric quality measures for end-of-life care for children with cancer. The National Quality Forum is the large national organization that is the main clearinghouse and endorser of quality measures. The National Quality Forum has endorsed 23 measures of high quality end-of-life care for adults with cancer. So things like avoidance of the intensive care unit at end of life, palliative care involvement, and death outside of the acute care setting. They have endorsed 0 measures for children with cancer. And this matters. So if we can't define what something is, we can't measure it. And if we can't measure something, how do we improve it? So when programs or hospitals are doing initiatives to improve end-of-life care, what are they actually trying to improve? How do you evaluate if new end-of-life programs are effective if you don't know what high-quality care is? How do we know which programs are providing high-quality care? How do we know which children are at risk of receiving low-quality care? Those adult quality measures that I mentioned have provided a framework for exactly that, a way to compare care between programs, identify disparities, and help ensure a basic standard of end-of-life care for all adults dying of cancer. Children do not currently benefit from standardized quality measures. The pediatric palliative care research community has identified this gap and calls for establishing core quality indicators for pediatric hospice and palliative care as a research priority. And as Dr. Maurer mentioned, establishing quality measures for end-of-life care for children with complex chronic conditions and leveraging those quality measures to reduce disparities in end-of-life care is my research focus. The problem is we did not cover how to develop quality measures in medical school, so had to figure out what that process is like. Fortunately for me, the National Quality Forum and the Centers for Medicare and Medicaid Services have a framework for quality measure development, starting with measure conceptualization. So what exactly is high quality care? How do you define what high quality care is? Then moving into measure specification, kind of some of the nitty gritty of exactly who the measure should apply to. Does there need to be risk modification for different groups? Then moving into measure testing to figure out whether or not we can actually use those measures in the real world setting, before finally moving on to actually implementing the measures, which can allow us to identify variation and respond to disparities we find. So today I will start with what I have done in pediatric oncology to define high quality end-of-life care, and then also talk about how we can use this process in other groups and how this framework can really help us improve care both locally and nationally. So the first step in my work was to develop these quality measures. And as with the existing quality measures for the adults, I started with the stakeholders. In particular, started with bereaved families. So I conducted semi-structured interviews with 28 parents representing 24 children with their perspectives on what is high quality end-of-life care. I started with the focus group script that had been used to develop those adult quality measures and modified it for appropriateness in pediatrics. I was in California at the time and really wanted to ensure that we were capturing the Hispanic voice, a voice that is frequently not heard in research, and a group that we know has different patterns of end-of-life care than non-Hispanic white children. So intentionally sampled to have half the families be Spanish-speaking only. The families had incredible stories to tell, not surprisingly, and had a lot to say about what is high quality care. First, the majority of the families preferred a home death for their child, and I'll share illustrative quotes for each of these in a minute, unless that home support was inadequate and could not make that a reality. The families talked a lot about supporting natural death and at the same time wanting to continue anti-neoplastic chemotherapy to treat their child's cancer. Families also talked about the importance of policies and programs that allowed the families to spend as much time with their dying child as possible and not have to worry about other day-to-day things. For most families, this was the first time they had navigated any of these end-of-life issues and really needed a lot of education and guidance so they could make the appropriate decision for their child and their families. And a lot of feelings of abandonment by the families. And so really highlighted the importance of continuing care at end of life and beyond for these families. So with that home death preference, their dying child said, I want to make sure that I get out of the hospital in 24 hours. I don't care what the doctors have to do. However, that was not always possible due to lack of high quality pediatric hospice. At home, the nurse wouldn't come, and then the nurse didn't seem to be paying enough attention to my daughter. We told her, their dying daughter, that we were going to bring her back to the hospital. And since she had spent almost her entire disease in the hospital, she didn't want to, but she gave in because she was in a lot of pain, a lot of pain. It was unbearable pain. And families supporting a natural death. If you need to plug your child into a piece of machinery that's going to keep them alive, then all you're doing is you're making that child suffer. But at the same time, wanting to continue treatment for their cancer. I would have said yes, they should continue trying to cure their child. Because I think that's what all parents want, to try. And policies and programs that really removed barriers to spending time with their children. A community agency helped us because they gave us a card for gas, so it helped us. However, not all policies help families spend time with their children. But we're at end-of-life care. Why should we not be allowing siblings and things like that? It was before COVID. And families needing information so they could make appropriate decisions for their child. Like that was extremely horrific to have your child's body put in the bag and taken out the front door. So if I had known what they do, I probably would have had my husband carry her out to the van. And feelings of abandonment. Like they didn't want to have her there anymore. So some of those quotes fell on that spectrum of comfort care versus prolonged time, what are families primarily focusing on? And this was really important to me because some of my earlier work showed that Hispanic children with cancer were more likely to die in the hospital and have medically intense end-of-life care than non-Hispanic white children. But whenever I present that data to anyone, they'd say, that's okay, that's what Hispanic children want. I'm like, we don't actually know that. So I thought that these interviews were a wonderful opportunity to try and dig into whether or not Hispanic children receiving more medically intense care was actually goal concordant for these families or not. So we pulled out all the quotes related to that comfort care versus prolonged time spectrum and scored them on a 5-point scale, with 1 being strongly in favor of comfort care, home death, 2 slightly in favor, 3 being neutral, 4 and 5 being in favor of medically intense care and hospital death. And here you see those results with the scores for all the quotes together with overall, and then broken down by type of intervention. So hospital death, medically intense end-of-life care, and chemotherapy. Also have all the interviews together and then broken down by the English-speaking families and the Spanish-speaking families. And just to remind you that 1 represents favoring comfort care. So first, you see that overall, the families slightly favored comfort care over prolonged time, and with a median score of 2.5, with the neutral being 3. You also see that Spanish-speaking families trended, not significantly, but trended towards more support of comfort care. So English-speaking families overall 3.0, Spanish-speaking families 1.7. For hospital death, 2.4 versus 1.5. Medically intense end-of-life care, 2.4 versus 2. Chemotherapy, 3.1 versus 2.8. And then you also see that families did not view hospital death, medically intense end-of-life care, and chemotherapy equivalently, all of which are quality measures for adults with cancer. So hospital death was 1.6, medically intense end-of-life care 2.4, and chemotherapy 3.2. So going back to the Spanish-speaking families wanting more supportive comfort care, we did basically the exact same interviews in Alabama and also intentionally sampled to have half the families be Black and the other half be non-Hispanic white, and found the exact same pattern. So we found that Black families trended non-significantly towards more supportive comfort care. However, when we actually examined patterns of end-of-life care, Black children were getting more medically intense end-of-life care. So the pattern, and I just want to take a minute to kind of talk about this issue and why this might be. So again, in California, despite preferences that are opposite to this, Hispanic children were more likely to die in the hospital and have medically intense end-of-life care. And in Alabama, Black children were more likely to die in the ICU and spend more days admitted at end of life, despite the interview showing a preference to the opposite. So really, why is this is one of the fundamental questions that I want to answer and then address. So I will posit a few things that I think about as potentially underlying these issues, but things that we really need to dig further into. So one of the things potentially driving this is how wishes are enacted. So in a multi-institutional study of adults with cancer, they looked at preferences for both Black and white patients. They found that when both Black and white patients wanted medically intense end-of-life care, the white patients were 3 times more likely to receive medically intense end-of-life care than the Black patients. And conversely, when both Black and white patients had documented preferences for a natural death, every white patient that wanted a natural death received a natural death. However, Black patients who wanted a natural death were no more likely to receive it than those who wanted medically intense end-of-life care. So there are some things with, even when Black and white patients have the exact same wishes, we enact those wishes and respond to them very differently. There's also provider bias that goes into this. So this was a beautiful multi-institutional study of children with cancer and their families, as well as their providers. So there was a survey of parents that asked if they wanted as much prognostic information as possible about their child or not. And you see here that the vast majority of families wanted as much prognostic information as possible about their families. And that was true regardless of race and ethnicity. So white families, Black families, Hispanic, Asian, all wanted as much prognostic information as possible. But when you ask providers how much information they thought the families wanted, across the board, providers underestimated the amount of prognostic information the families wanted. And that was particularly striking and most significant for Black and Hispanic families. So kind of how we talk to families and what we think families want could potentially be influencing whether or not reality and preferences match. Another piece of this that I think about is perceived medical discrimination. A lot of the data on this comes out of California because the California State Health Survey has included questions about perceived medical discrimination for almost 20 years. They have found that perceived medical discrimination is associated with lower perceived quality of care, delaying or foregoing medical care, including less cancer screening. So a lot to investigate moving forward to figure out how we can improve goal concordant care for patients, particularly for underrepresented minorities. Moving back to the framework, what did I do with those interviews with bereaved families? So we used a modified Delphi approach to expert opinion gathering, which was developed by the RAND Corporation and is routinely used in quality measure development. So we combined the findings from those bereaved family interviews in California, as well as interviews in Alabama, and those previously endorsed adult medical intensity measures, those things such as avoiding the intensive care unit, avoiding chemotherapy, and death at home. By combining those, we came up with a list of 20 proposed measures for high quality end-of-life care for children with cancer. Our research team, really my phenomenal CRA, developed an evidence packet with information for and against each of those 20 proposed measures about whether or not they represented high quality end-of-life care for children. We supplemented that evidence in the literature with the experience of our bereaved families. For our panelists, we sought nominations from professional organizations such as the American Academy of Pediatrics, the American Society of Clinical Oncology, and the American Academy of Hospice and Palliative Medicine. Together, we had 9 experts from a variety of fields, including pediatric oncology, pediatric palliative care, nursing, social work, and hospice. We provided them the evidence packet and asked them to think about what is high quality end of life care for children with cancer, and asked them really to consider disease-related deaths rather than treatment-related mortality. So kids dying of universally poor prognosis situations like diffuse intrinsic pontine glioma or relapsed solid tumors, rather than children dying of infection when they were just diagnosed with cancer. After our phone call explaining the modified Delphi process and reviewing the evidence packet, the panelists scored the 20 measures on a 9-point Likert scale, evaluating both the measure's importance and feasibility. And we'll just focus on importance today. And 9 was the most important or feasible. As they were scoring, they were asked to consider the evidence we provided as well as their own personal experience. During this survey, panelists had an opportunity to comment on measures and a free response portion. Many panelists asked for the addition of very similar measures, so we added 2 measures at this phase. The panelists then participated in a 4-hour conference call where we talked about the evidence for and against each of the measures, as well as the first round scores, and then had open discussion period for each of the measures. The panelists then rescored the now 22 measures, and as is standard in the modified Delphi process, the measures were endorsed if they had a median score greater than 7. So in general, were thought to be important, and 7 out of 9 experts rated it as more than 4. So there weren't panelists who thought it was very unimportant. We ended up with 16 endorsed measures and 6 unendorsed measures. The 16 endorsed measures fell into 4 broad categories, including avoidance of medically intense end-of-life care. And we'll show you these measures in a moment. Location of death, supportive care services, and hospital policies and programs. For each of these 4 categories, I will show you the endorsed measures as well as their median importance score. The first category is avoidance of medically intense end-of-life care. There were some concerns about calling avoidance of medically intense end-of-life care high quality care, as it is in adults, would prevent some families who wanted medically intense end-of-life care and ICU admission from receiving that care that they wanted. Therefore, only 3 of the 6 measures related to avoidance of medically intense end-of-life care were endorsed, measures that the panelists thought would cause suffering to the child or reflected a lack of sufficient home support. So they endorsed avoidance of death in the intensive care unit, avoidance of 3 or more emergency department visits in the last 30 days of life, and avoidance of intubation in the last 14 days of life. And the second category involves location of death. 2 of the 4 proposed measures were endorsed, both around dying in the preferred location rather than dying at home like the adult measure. So they called for documented preferences for location of death, and then of those with documented preferences, who actually died in their preferred location. The third category is supportive care services, which had 7 of the 8 proposed measures endorsed. And the panelists really wanted to make sure that both supportive care services were involved and that supportive care services were involved for sufficient time to actually have meaningful involvement. So they called for pediatric palliative care or hospice involvement in the last 30 days of life, and to ensure sufficient time for meaningful impact, that if pediatric palliative care was involved, it was involved for more than 14 days, and hospice for more than 5 days. They also called for assessment of sibling needs and financial challenges within 60 days of death. The final category is hospital policy program and programs. All of the proposed measures in this category were endorsed without much discussion. They called for the presence of a bereavement program and pediatric palliative care services at the treating center. They also called for policies to eliminate visiting hour, age, and number restrictions at end of life, and then called for a program to educate families about the events surrounding death. The panelists did acknowledge that some of these measures, particularly presence of a bereavement program and a program to educate families about the events surrounding death, are very nebulous. And ideally, in the ideal world, we would have these all laid out in terms of what components of a bereavement program and what components of a program to educate families about the events surrounding death are critically important. However, they felt just having the measure was a really important starting place, and we can continue to work on elucidating all of the details moving forward. The panelists also called for more measures of goal concordant care beyond just the location of death measures. They also called for more measures of patient, or really child, and parent reported outcomes to better actually capture the experience. Some of the measures that were not endorsed are measures that are frequently used in the adult world, including home death. They acknowledge that many children and their families prefer a hospital death, potentially because they feel so incredibly comfortable on the oncology ward, they have concerns about siblings, and because currently the state of hospice access in this country for children is not what we need to be able to have all children be able to achieve a home death, and really thought that until we have access to high quality pediatric hospice for all children, home death is not a possible reality for many children. Similarly, they did not endorse time at home, as it may not be goal concordant for many children and their families. And they did not endorse avoidance of chemotherapy at end of life, really recognizing the challenges of giving up hope in pediatric oncology, and really both for parents and their providers. And that right now we have so many low dose targeted chemotherapeutic agents that we can maintain that hope without causing undue suffering to the child. And that brings us to some of the key similarities and differences between those existing adult measures and these pediatric measures. So first, both measure sets involve some avoidance of medically intense procedures at end of life. They also call for supportive care services, and not just supportive care service involvement, but sufficient time with supportive care services. However, there are key differences. For instance, the pediatric measures are much less stringent about medically intense procedure avoidance. For instance, the adult measures call for avoidance of the intensive care unit for the entire last 30 days of life, whereas the pediatric measure just calls for avoidance of ICU death. Further, the pediatric measure set calls for death in the preferred location as opposed to death outside of the acute care setting for the adult measure. Again, maybe more goal concordant in pediatrics, and because of the state of access to high quality pediatric hospice in this country right now. The panelists also endorse novel measures in pediatrics, including financial and sibling assessment at end of life and eliminating the visiting restrictions at end of life, which is particularly important in pediatrics, given the high number of children with cancer who die in the hospital. Now that I have these quality measures, what do we do with them? Because a list of what is high quality end of life care does nobody any good unless we actually implement them. So the next steps directed by the quality measure development framework are figuring out the measure specification, so exactly who these measures should apply to, and testing them to figure out if we can use them in the real world setting. To determine the measure specifications, or that really the denominator in quality measures, who the measures apply to, we are using a technique called the nominal group technique to gather expert opinion. And standardly in nominal group techniques, you want to ask a kind of a one-line, very simple question. We learned very quickly as we were testing our question that that was not possible in this area because people in the field feel so strongly that high quality care is important for all children. Really had to be careful that what we are trying to do is to figure out how to measure high quality care and compare apples to apples, as opposed to making a value judgment about who should receive high quality care. So our very long-winded question for our panel was, we want to use these quality measures in a subset of children who are dying of their underlying cancer rather than complications of treatment in an otherwise curable disease. Please list factors such as diagnoses, conditions, prognoses, or clinical situations that you think indicate that a child is likely to die of their cancer. So we have conducted 4 panels and have 2 more to go. and have really had an amazing response. I actually sent out 30 invitations and asked people to invite other people, and was trying to, get child life and social work and hospice. And we ended up with 60 people signing up, which I think partly shows how important this issue really is to the field and how passionately people feel about it. We also, for all the panels, have to really emphasize that this is not about who gets high quality care. It's about how we measure high quality care, because of the passion that people in the field feel about high quality care for everybody. And we are in the process of analyzing those results, which is exciting. So TBD. The next piece of this is these measures were designed to be used and to be abstracted from the medical record, particularly those individual level measures. So can we actually do that? The first question is feasibility. So can the data be abstracted from the medical record on a reasonable time frame? Does a medical record abstraction take 5 minutes or 5 hours? The next question is, how good is that medical record? You all know that we do not necessarily document well. And so one question is, does the medical record actually say what is happening? Is it valid? So with that, we are pairing the medical record review with bereaved family surveys to ask the question, does the medical record actually agree with what the parent says happened at end of life? And then reliability. Do two people looking at the medical record actually agree about what happened? So having two separate abstractors abstract the data, and then we can answer the question of, do the medical record abstractors agree? And we have established a 3-site consortium to make this happen and are starting with data collection next month. So, and then also realizing that these surveys with bereaved parents are a great opportunity to start working on the panelists' call for more measures of parent-reported outcomes. The American Academy of Hospice and Palliative Medicine partnered with the National Coalition for Hospice and Palliative Care and RAND to develop 2 patient-reported experience measures for adults with palliative care. And they have not been tested in pediatrics, but seem very relevant. And so we will see how they go when they are adapted for pediatrics. So we will ask the parents how much the patients, or really the child and the parent, felt heard and understood at end of life, and how much the child got the help they wanted for pain. And then how do we go from here to actually improving care? So I will show you how this data and this framework can improve care both locally and nationally. So using data to support clinical care locally can involve a comprehensive needs assessment to figure out what exactly the gaps in care are, followed by targeted program development, and then program evaluation to see how it is actually going. So we started an initiative to improve end-of-life care for children with advanced heart disease at Children's of Alabama, and largely started that because some of the cardiologists came to me and wanted to partner on research around end-of-life care for children with advanced heart disease and wanted help with local improvements. And so really a partnership that was driven by the local division's needs. So I've talked about palliative care being a critical part of high-quality end-of-life care. So we wanted to see, what does that look like for children dying of advanced heart disease at Children's of Alabama? So we found, of the 128 children that died of advanced heart disease during the preceding 8 years, only 23% had a palliative care consult. So less than 1 in 4 children were getting palliative care. As usual, I wanted to not only know what percentage of children were receiving palliative care, but I wanted to see if there were disparities in who was receiving palliative care. Was this random, or was this more bias driven? So in multivariable regression analysis, controlling for a host of other clinical and sociodemographic factors, we found that children less than 1 at time of death and Black children were less likely to have a palliative care consult than other children. At the same time, I wanted to know if this was actually a problem. So if every parent who had had their child die was like, oh my gosh, we got phenomenal end-of-life care, we're having great bereavement outcomes, who cares? Fine. We can have 1 in 4 child receive a palliative care consult, and that's okay. But we needed that data. So in interviews with bereaved parents, we repeatedly heard things like this. And so when O's pediatrician told me to ask for palliative care, I went ahead and asked the doctor. He said, no, we are not giving up on O. There's still a lot that we can try and do for him. And providers. We were going to be starting an initiative to improve palliative care consultation and access in the cardiovascular intensive care unit. But if we did a program that providers had no interest in, it wasn't going to go anywhere. So for a separate quality improvement initiative, we had conducted a hospital-wide survey of providers' thoughts on pediatric palliative care and what could be done to improve pediatric palliative care at Children's of Alabama. A lot of providers made comments about the importance of continuity of care for patients in the hospital and wanting more primary palliative care physicians to be following the child. Talked about the importance of outpatient availability for ongoing follow-up of children after discharge. And providers wanted more systematic involvement with patient populations at high risk for adverse outcomes, most notably being death. We took all of this data and formed a task force of 2 cardiology intensive care unit attendings, a cardiology social worker, a palliative care physician, and myself, and wanted to think critically about how to improve palliative care uptake in the cardiovascular intensive care unit and address disparities in care by making it more systematic and more of a trigger consults. We also wanted to address the provider's concerns about continuity of care. So we ended up embedding a palliative care physician in the cardiovascular intensive care unit to have one point of contact for the cardiovascular intensive care unit consults. Luckily for us, there is a palliative care provider who is dual certified in palliative care and intensive care unit, so can really bridge some of those gaps. She attends the weekly case conference to both keep her ears out for patients who are not receiving palliative care who may benefit from it, and to improve communication between the palliative care and the cardiovascular intensive care unit team to really work on culture change around these issues. She then sees a set of patients automatically, including kids with congenital heart disease who are in the cardiovascular intensive care unit for more than 7 days. So trying to have more systematic triggers rather than relying on providers and introducing the bias into the referral process. And then in addition to those standard kids, she also will see any children that the cardiovascular intensive care unit team want her to see. She then follows those kids not only in the cardiovascular intensive care unit, but also when they transition to the floor. And we are working on a plan for her to continue with outpatient follow-up of these kids. We presented the plan to the cardiovascular intensive care unit team in the spring, made a couple of modifications, and then launched in August. Of course, it's going to be fantastic and there's going to be no issues. No, we need to evaluate. And so really have thought critically about how we evaluate the program and who the critical stakeholders are to make sure that we are monitoring and responding to issues as they arise. So clearly are talking to parents. We are doing a patient satisfaction survey of families who are receiving palliative care and can analyze the cardiovascular intensive care unit experience separately to see how parents are feeling about the initiative. We're also checking in with the cardiovascular intensive care unit team, including the bedside nurses, social work, clinicians, really the whole multidisciplinary team who can be impacted by palliative care involvement. And then also talking a lot to palliative care about what this burden is on their team. Cardiovascular intensive care unit clearly has a lot of palliative care needs, but they are only one small part of the hospital. And how does this work impact their ability to take care of other children in the hospital who have palliative care needs? And what that work looks like on the national stage. I'm not the only one who thinks that this work is critically important. So the Palliative Care Quality Collaborative is a national collaboration of the American Academy of Hospice and Palliative Medicine, the Centers to Advance Palliative and Supportive Care, and other agencies to collect robust palliative care quality measure data. The current issue is that pediatric programs are currently reporting on quality measures that were mainly designed for adults. So really working hard with PCQC so that when we have measures that we can feasibly collect in the clinical setting that are designed for children, we are poised to partner with them to have national data collection on quality of end-of-life care on measures that are actually applicable in children. And that will help us identify on a national level which programs may need to work on which areas of providing high quality end-of-life care and which children are at risk of receiving poor quality palliative and end-of-life care and are in need of targeted interventions to increase equity. I want to acknowledge that a lot of what these local and national efforts are involved is really closely linked to quality improvement and our lovely PDSA cycles. However, my struggle with quality improvement in palliative care right now is how do you know what you're targeting? Unless we have defined what quality care is, what should quality improvement efforts be working on? What are the benchmarks they should be targeting? And so hopefully with this data, we can have more informed quality improvement efforts in palliative care. I am a pediatric oncologist and know that there are a lot of children beyond children with cancer who are dying of complex chronic conditions who are really in need of quality measures and improvements in palliative and end-of-life care. So starting to develop quality measures for other groups, in particular, starting with children with advanced heart disease because of those collaborations. And clearly there's going to be measures that are very specific for pediatric oncology, like things around chemotherapy. And we'll see what seems to be very specific for cardiology, potentially things around procedures such as heart surgery and catheterization. And at the same time, I think there will be a lot of cross-cutting measures like things such as sibling and financial assessment at end of life. But we will find out. And it'll be really interesting as we dig into these different disease categories to learn what is disease specific versus what's more specific. Also, all of my measures focus on the last 30 days of life. Clearly, there are a lot of palliative care needs prior to 30 days before life. And really, the American Academy of Pediatrics and other organizations calls for palliative care to be integrated into the continuum of care from the time of diagnosis on. And so how do we develop quality measures for the whole spectrum of the illness related to palliative care? A lot of this work also has implications for policy. We discussed hospice involvement, for example. So what policies on both the legislative and the insurance levels can ensure access to high quality pediatric hospice for all children? So potentially things like how do we address nursing reimbursement rates? How do we ensure that concurrent care is available to not just children on Medicaid, but children on private insurance as well? And so really a lot of ways that we can, with this quality measure data, can potentially lobby for policies to improve equity in care. One of the most important policy tie-ins that I see is value. So part of these changes and part of what we need to do is show the value that we provide with palliative care and with end-of-life care. Value-based repayment is a tremendously hot topic and was a core component of the Affordable Care Act. So value is quality over cost. So how do we show that something adds value if we don't actually know what quality is? And I worry that if we do not have pediatric specific quality measures, we'll be left with defining value with adult quality measures, which as we saw, some are applicable in pediatrics, some are not. And hopefully with these quality measures, it'll be easier to show the value that palliative care adds to get appropriate reimbursement and hospital program buy-in for palliative care. And particularly, some palliative care activities like bereavement follow-up that are not directly reimbursable, we can show that they're adding a lot of value still. So looking at how quality measures can impact value, the value-based repayment argument and process. So I've now created a problem. So a lot of the work that I have presented and others' research really shows the benefit of palliative care. So now we're saying that a marker of high quality end-of-life care for children with cancer includes palliative care consults. So we need Dr. Maurer and his team to provide meaningful palliative care to all children dying of complex chronic conditions. At least you have job security. So how do we meet that demand? So clearly we need to continue with state-of-the-art pediatric palliative care fellowship programs and make sure that hospital programs buy into the idea that palliative care and really a robust multidisciplinary palliative care team is an integral part of pediatric care. And hopefully by showing the value added, we can help make that happen. The other key aspect of meeting the palliative care needs is to train clinicians to provide excellent primary palliative care. The general pediatricians, pediatric pulmonologists, pediatric oncologists like myself and others can do a lot before patients need specialty palliative care. However, that means we need to have better training in primary palliative care skills. So medical students, residents, non-palliative care fellowships need evidence-based difficult conversations integrated into their training. which of course means that we need people who know how to train people in evidence-based difficult conversations. So it is really critically important to have programs like Vital Talk developed by people here in Pittsburgh that help disseminate evidence-based communication and how to teach evidence-based communication. So things like how to respond to emotions in difficult conversations, talking maps, and other key elements of evidence-based communication. So hopefully through continued pediatric palliative care training programs, hospital leadership buy-in, and integrating evidence-based difficult conversation communication into training, we can meet the primary and specialty palliative care needs of children. So today I have shown you the process of quality measure development and implementation, both my research and how quality measures are tools that can be implemented both locally and nationally to improve palliative and end-of-life care for children. So really, as a field, I hope we can define high-quality palliative and end-of-life care and deliver on it for all children. So, and a huge thank you to a really rich mentorship, research, collaboration team and funders. And of course, my biggest thank you goes to the families whose voices and stories really have shaped this work.